Okay, so I'm Tom Duran. I'm a pharmacist. That's my background. I was working in the Indian Health Service. I had worked for Indian Health Service for 20 years. My mother had worked for Indian Health Service for 28 years, and her mother had worked for Indian Health Service for about 25 years. So we had a long history of working for Indian Health. When I entered Indian Health Care, I did my residency in Gallup, New Mexico on the Navajo Reservation. Then I transferred to Anchorage, Alaska, and worked with all the Alaska Natives up there at the medical center. And then I transferred to Shiprock, New Mexico, back on Navajo. Then I transferred to Ignacio, Colorado. And throughout my 20 years in Indian Health, I was a pharmacist, I was a chief information officer, and a professional quality services manager. And then I also was chief executive officer at my last job, and I was managing and building a tribal health system that was providing complete comprehensive care. Part of the system was funded through the federal government, through Indian health funds, and part of it was funded through tribal funds for tribal members only. Navajo and Southern Ute are both my home reservations. My grandfather, my Che, is Navajo, and then my grandmother is Southern Ute. And so I wanted to make sure that I was able to have some impact on my home reservations before I kind of moved around. This particular position came open last July, and I applied because I was looking to change out of my current role as CEO into kind of a different role. Not expecting this position at all, but was excited to get this position because this position really has a global reach in terms of CMS. This position isn't focused on one part of CMS, it's focused on all parts of CMS. My purview is the Pacific area, which includes Hawaii, so all the islands, the Hawaiian Islands, and then Guam, Samoa, and Saipan. We do have some issues in all areas. And what I've learned throughout my career is that every location is different. There was a question earlier in terms of some of the health aspects from one reservation to another. And I can tell you when I went to Alaska, I was very surprised to be able to use antibiotics to treat infections that typically you wouldn't use in the lower 48 because the infections were resistant to those antibiotics. Whereas in Alaska, those antibiotics were very effective. So that was very early on in my career, but it really helped me recognize that treatment and healthcare is so different and is based on local community. And so there's a lot of importance to being part of the local community. And for myself, I've always considered myself somewhat of a visitor, respectful of a community, and doing my best to help those communities. Now, granted, the last two jobs I had were on my home reservation, so I wasn't necessarily a visitor, but I was raised very traditional Indian, and so you'll have to forgive me at times because sometimes I won't look at an audience, and that's just my upbringing. Navajos typically don't look in the eyes of others out of respect for each other. So I'm kind of trying to overcome that just because of this current role. But once I get loosened up and start joking around, then I kind of get beyond that culture part of me. So thank you. Hopefully that answered some of your questions in terms of who I am. So I wanted to tie in part of CMS with the National Strategy for Quality Improvement, because a lot of people misunderstand what CMS is doing because they don't understand part of what's pushing CMS to do what it does. Part of it is the law. The law tells us we have to implement or do something. The lawmakers, of course, Congress passed the law. Then we have to implement it in terms of CMS. So the National Quality Strategy comes out from the Health and Human Services Secretary. It is a requirement for her to implement the national strategy through the Affordable Care Act. The Affordable Care Act requires it. And so and I'll go through how the national strategy was developed. But basically, in terms of a public health officer, we're looking at how do we measure healthcare to ensure that it's quality healthcare and that people are getting really good care. Because realistically, a lot of us, and when I think in terms of health, I think in terms of I'm a patient first. Because I received healthcare in Indian Health my whole life, except now, which I'm here on the island, so I have to receive care through the military. But throughout my career, I received all of my health care in the Indian Health Service facilities. So it was easy for me to understand some of the hang-ups and the deficiencies and the problems in the health system because I was a patient my whole life, as I am now, from a very early age. And my mother and grandmother would share with me some of the issues that they had in terms of Indian health and problems delivering care. And so I heard that very early on in my career, which kind of led me into who I became and what I do now. You guys won't know me, but I am pretty radical when it comes to health care. I do believe that we have to be very aggressive in terms of health care because it's literally life and death for people many times. And so we have to really make big efforts to move the system forward as quickly as we can, with as much information as we can. So the National Health Strategy was developed, and the strategy had 3 aims. It was to have better care, healthy people and healthy communities, and then affordable care. And we hear that over and over and over, but it is the foundation of what we want to accomplish in terms of CMS providing payments and care, as well as public health providing care. We want to make sure that we're providing a quality care. Now, for me, I can tell you that, and some of you are probably providers, one of our biggest obstacles has always been access to care. And I think the Affordable Care Act really was focusing a lot initially on how do we get people access to care? Because if they could get care, they'll be healthier, and if they're healthier, they'll live longer, and if they live longer, then when they enter different times in their lives, they'll be healthier at those times. So like, say for example, they get into the Medicare system, they'll be healthier when they get to that system, so it will be less of a burden on the system in terms of cost. We never think of the system being burdened in terms of providing care. We think of it sometimes in terms of the cost of care. And a lot of us know that the cost of care continues to increase, and that's really one of our biggest challenges. So I started my presentation out with collaboration, because I think that's the most important part of any effort when it comes to healthcare. We really have to collaborate if we're going to be successful, no matter what. And that includes collaboration from provider level to provider patient level to patient family level, and then to community level and tribal level, and then national level. We really have to collaborate, because if we don't collaborate, then we're really working independently of one another. And then when we get to the an intersection in terms of healthcare, we kind of find ourselves struggling to provide care, and the patient doesn't understand why the system's failing them. Because from a patient's perspective, the healthcare system can be so complex because they really don't know how to get through the system. And so what we're going to see with the Affordable Care Act is there's going to be some coaching and some volunteers and others that are going to help people sign up for the Affordable Care Act. And that will help them become aware of the Affordable Care Act as it's implemented, or excuse me, the exchanges as they're implemented. So collaboration is important, and we do believe it's important across all the health sectors, absolutely important. And I can tell you from my experience as a healthcare provider for 20 years, we did collaborate a lot. Pharmacists do play a key role, as do our nurses, as do our physicians, as does everybody in the healthcare industry. In fact, I'm an advanced practice pharmacist, and part of my background is I'm special trained in neuropharmacy. So I used to provide care to seizure patients and patients that had neuro disorder with a neurologist, and we worked collaboratively I would actually see patients, she would see patients, and then we would confer and communicate on all our patients in terms of what's our best treatment plan, what's the best medication to use, so on and so forth. We really saw some significant change in terms of our system. We started measuring our data, and we saw significant decreases in emergency room visits, significant decreases in admissions to hospitals for breakthrough seizures, and significant improvements in terms of compliance to their medications. And so we realized that the collaboration was so important in terms of working together. As time has progressed, though, many of you in the healthcare industry will hear the terms patient-centered care. And that is a huge push by accreditation agencies. It's a huge push by CMS, and certainly a huge push by the National Strategy for Quality Improvement. And it's a huge shift we're going to start seeing in healthcare, because literally you're taking the system from what typically had been very provider health system focused, where you went to see a patient, or excuse me, a provider, you never questioned the provider, and then the provider was always right and they always told you what you needed to do, so on and so forth. But now as the system's starting to evolve, we're starting to see patients become more educated in their care. They're starting to really look on the internet and seeing what's available to them in terms of treatment options. And then they come to the providers with a lot of questions, which is really good because it's telling us that these patients really care. And once a patient cares about their care, they can radically change their health themselves. And my own personal opinion is a patient really has to be involved in order to change their health. The health system can't change their health for them. The patient really has to be involved and kind of be directing their health, because it's very individual. The collaboration also consisted of a partnership with the National Quality Forum, which is an independent nonprofit organization. But basically what the collaboration was looking at in terms of the National Strategy for Quality Improvement was to try to find a way to identify standards and metrics that could be used nationally so that they could measure against those standards and metrics to ensure that quality is measurable and improving. And then also comparative, because it's important in a health system to compare yourselves to others in the health system. So if you're a small ambulatory clinic, you should compare yourself to another small ambulatory clinic of comparable size to see how you're comparing in order to improve your service, because every service can improve. And then in terms of the government, there's an interagency working group, and that's also important because what we found, and at least what I found throughout my career, was that a lot of times government programs were working independently and not collaborating. So we saw a lot of difficulty with crossover from the Veterans Administration and the Indian Health Service. For the past several years, I've been working, or I was working through the tribal system that I was working for to try to get the veterans and the Indian Health Service to work collaboratively. And it was always coming down to, well, who's going to pay for the care? Where are they going to be seen? Is the Veterans Health System going to be responsible, or is the Indian Health Service system going to be responsible? And at the end of the day, again, remember, for me, it always comes down to the patient. We want to make sure that the patient gets the care. The politics and the bureaucracy is an important part, but it comes after the patient receives the care. We really have to make sure our patients get care first, because that's what's most important. So measuring quality is important in terms of how do we make sure we're improving the system. And so there, again, were different ways of looking at measurements, but you know, as a provider myself, and providers will say this, you know, providers are trying to provide care, and it's really hard to burden providers with saying, okay, you need to measure how many patients you gave an antibiotic, or you need to measure how many patients got readmitted to a hospital, or you need to measure how many patients were screened for depression. And all of those things are burdensome in terms of providers, trying to provide care to patients within a 15-minute slot. And so that's where the electronic health record can be and has been very beneficial, because it does measure those at times if it's built into the system. There is an increasing focus on clinical outcomes and patient-reported experience measures. For the longest time, there's been primarily a focus on clinical outcomes, and I gave you some already. But now we're looking at not only the outcomes clinically, but also what's the patient's experience. Did the patient feel better? Did the patient feel like they were a part of the system and part of the decision-making process? And if not, how can we help them to become more of a part of the decision-making process? And so we want to make sure that they have quality patient experience in the system. For CMS, when we talk about patient experience examples, there's a few that I linked up to this slide, and one of them was hospital value based purchasing program. And I'll go over that a little bit more in a minute. But basically, the goal is to link clinical outcomes and patient-reported experience of care to provider payments. And I'll go over that in just a few minutes. But there is an incentive program, and we call it the Hospital Value-Based Purchasing Program. And then there's our end-stage renal disease quality incentive that our dialysis dialysis center employee probably is familiar with, but CMS does provide in-center dialysis patient reimbursements for high-quality patient-centered care. Again, remember, it's patient-centered, and we're really starting to look at patient experience. Now, the National Quality Strategy has priorities, and you saw them in the beginning in terms of better care, healthy people, healthy communities, and affordable care. In addition to those three aims, there's priorities that are connected to those three aims, and you're familiar with them, right? Making care safer is an important aspect of healthcare, because there are errors in the healthcare system, and sometimes it's because there's so many patients using the system, and other times it's just because an error was made, and nobody's perfect in terms of delivering care, unfortunately. And other times, a patient may have an illness that they're not aware of and the provider's not aware of, and then the provider starts treating them with whatever medications, and then the patient has an adverse reaction to those medications because of their other illness that was underlying that the provider didn't really know about. And so we know that care can be harmful if not monitored, and so one of the big goals, of course, is to decrease adverse drug reactions, or the wrong drug to the wrong patient at the wrong time for the wrong reason. Ensuring patients and their families are engaged as partners in their care. I already went over that, but I can't overemphasize the importance of collaboration amongst, say, all of us and amongst our patients as well as providers. We have to ensure that there's effective communication, and then we want to make sure that prevention is a priority in terms of our health system. And that's a challenge. I could tell you from my past experience, it is challenging when you know that you have so much money and you're trying to provide care in terms of acute care and chronic care, and then you try to add prevention efforts on top of that, recognizing that prevention is a long-term effort and you may not see your payoff immediately. So you're doing all these prevention things, but you're not seeing a change in your system or your quality or your numbers, because your patients aren't getting cancer, and they aren't having asthma breakthrough, and they aren't getting breast cancer and other things like that, because you're preventing them, but you're not seeing the illness. So it's kind of a catch-22. You want to make sure you're preventing, you want to shift some of your funds that direction and prevent, but you also have to recognize that you might not be able to measure very effectively that you prevented an illness because they didn't catch the illness, right? That can be very challenging. Another priorities, we're working with communities to promote wide use of best practices to enable healthy living. My motto when I used to be CEO or even chief pharmacist is, programs can be good as ours, but none can be better. That's always what I told my staff. You know, if you have to remember a vision, just remember that programs can be good as ours, but none can be better. And what that meant, and I told them, was we will always monitor every other system around us, and if they're doing it better, we want to adopt what they're doing so that they're not better than us, because they can be good at us, but we don't want them to be better. And so we looked around and we made sure that we were adopting different styles of care or different treatment plans in order to make sure our patients were getting the best care possible. And then, of course, making quality care more affordable is an important part of providing health care, and that is a huge challenge for all of us, and part of it is the cost of care continues to increase. In terms of national quality strategy, there's a lot of information out there. I included the websites that you could go to and look up. There's volumes of reports that they present to Congress about our progress in terms of how we're measuring and progressing to address some of the needs within terms of the healthcare industry. I'll stop there for a second to see if you have any questions, and then I'll move into CMS programs. Okay, so CMS, as you know, is a very large system that provides care to people. CMS is not a huge federal program in terms of number of employees. But we do impact the whole health system in terms of our outreach and our programs. As you know, Medicare and Medicaid Child's Health Insurance Program is monitored and managed in terms of CMS. We really keep on top of those. And 1 in 4 Americans receive Medicare, Medicaid, or Child Health Plan, or CHP. Medicare enrollment has increased from 19 million beneficiaries in 1966 to now over 50 million beneficiaries across the United States. So that's a lot of people receiving care through one of CMS's programs. And over 1 billion Medicare claims are processed annually. That's a tremendous amount of claims, and I can tell you in my CEO experience, I did do business office and billing, accounts receivable, and posting, because I'm kind of a hands-on type of guy. And I can tell you claims is pretty extensive in terms of printing them, entering the information, doing data entry, and then of course our coders would do the coding. So I wanted to go a little bit over a program that you're probably going to hear about that's a pretty big topic in terms of Hawaii. And our suppliers for DMEPOS have raised some issues and concerns. But DMEPOS stands for Durable Medical Equipment, Prosthetics, Orthotics, and Supplies. And what happened was the Medicare Prescription Drug Improvement Modernization Act of 2003 mandated the development and implementation of the DMEPOS competitive bidding program. And so that's the law that told us that we would implement it. And then the Affordable Care Act expanded the program as we're implementing it right now. And so how the program works is that we have durable medical equipment suppliers who have to submit bids, and they've already submitted bids for round 2. And the suppliers that submit bids, they will set a payment scale for specific equipment in specific areas. And so these suppliers have submitted their bids. They're getting notified now if they were awarded a contract, and then they'll be able to be suppliers for the CMS DMEPOS and receive CMS reimbursements. This is a big change from how CMS used to pay for durable medical equipment. Contract suppliers will be those who offer the most competitive price, meet eligibility requirements, and quality and financial standards. This is a huge change for the suppliers in terms of they have to measure their quality and report it and ensure that our patients are getting the best care and quality service possible. And so you can imagine going from not having to report quality and measuring metrics to now having to do it. It's a big transition, and I personally hear quite a few complaints on the island. They have to be accredited by an independent organization in order to be a DemiPost supplier. And so I don't know how many of you are in the healthcare industry, but if you go to like a nursing home, or you go to a hospital or an ambulatory care facility, those facilities are accredited. And sometimes you'll have CMS that comes in and does the accreditation. Other times you'll have a state accrediting group on the island. There's one that goes around and does accreditation. Or you'll have ambulatory systems use the HHHC. And then you have Joint Commission, which is for hospitals. Okay, and so you have these independent accreditors that go around and they accredit facilities. So you want to make sure as a patient that whenever you go into a facility that that facility's accredited, because if it's not accredited, then there's no standard that the facility's living up to in terms of they're not meeting the national standards because they're not being accredited and they're not reporting those standards, okay? And in order to receive Medicare payments in a facility and Medicaid, you do have to be accredited. And so the program, only contract suppliers will be able to provide competitively bidded items, okay? And they will be the only ones who will be able to file claims with Medicare for payment of competitively bid items and supplies. Contract supplier charge cannot exceed whatever the bidding levels are set at. And so a provider cannot charge the patient above and beyond what the Medicare fee schedule allowed and their deductible. Now, round one occurred in January 1st, and it occurred in 9 areas. And then what CMS saw in round one in those 9 areas, that there was $202 million in savings that first year. And what they also saw was that there was not a change or a decrease in quality. The patient still got the same level of quality service, but CMS was able to save $202 million. And then the lawmakers, of course, passed the law and implemented it further and expanded the program. So round one was completed, and the contracts are being recompeted for those 9 areas because they were round one. Round two is now starting, and it'll start July 1st, and it's expanding to 91 different locations, and one of those locations is Honolulu County. So it is Honolulu. It's not the rest of the islands, just Honolulu. So Oahu, all of Oahu is included. And then there's going to be a national mail order program that's already been tested, and it's for diabetic testing supplies, and it's targeted to go into effect July 1st as well. It expired December 31st. But CMS, rather than recompeting it and starting it in January, CMS decided and elected to restart it July 1st with the recompeted round one and round two. The National Diabetic Mail Order Program includes all of the United States, including the 50 states, District of Columbia, Puerto Rico, U.S. Virgin Islands, Guam, and America Samoa. In terms of our DemiPosts, who will be affected? So beneficiaries who have original Medicare, those who have A and B, those are the ones who will be affected. Patients can find out if they're in a CBA or competitive bidding area by dialing 1-800-MEDICARE. That's probably the easiest way, or even going online if they have internet. And again, Part C or Medicare Advantage, enrollees can use suppliers designated by their plan, so they really won't be affected. I've already mentioned that Hawaii is included in round two with the 91 metropolitan statistical areas. Guam will not be, and Samoa will not be, and only Honolulu, okay? The other islands won't be affected. However, there are some caveats to this, so I'll try to cover those as we move along. So if a person lives in a competitive bidding area, they almost always have to use a competitive bidding supplier. Doctors and treating practitioners and hospitals can supply certain items if it's like an emergency type of situation, but normally they have to use a competitive bidding area supplier. And nursing facilities can only supply directly if it becomes a contract supplier. for non-contract suppliers, and there will be some that, you know, are in these metropolitan statistical areas, patients that have Medicare A and B and want to be and want their supplier reimbursed by Medicare A and B cannot use a non-contract supplier. Okay, now if the patient elects to use a non-contract supplier, the supplier is required to give the patient what we call an advanced beneficiary notice. They have to notify the patient that they're happy to provide the medical equipment. However, the patient will be responsible and agrees to pay the entire amount. What I told the suppliers at my last presentation was, if they don't have an advanced beneficiary notice that's signed by the patient, then they cannot bill the patient for the charges. The supplier would have to essentially absorb those expenses themselves. They have to make sure that the patient signs a waiver in order to have the patient pay them directly, because Medicare or CMS will not be paying for the supply. So wrapping this part of it up, points to remember: the program does not affect which physicians or hospitals beneficiaries use. The beneficiary may need to change suppliers for Medicare to pay. Sometimes they've used their supplier for years, and their supplier may have not put in a bid to be in a competitive bidding DMEPOS supplier, or they may just have said, I'm not going to do that. And so a patient may have to change their supplier. Or they may be able to grandfather in their supplier at the very beginning if they follow certain protocols and processes which are on our website. I don't want to go into those extensively because it would take some time to explain, but a supplier can be grandfathered in. This is where you could get more information about the DMEPOS program, and it's included in your handout. But I did want to say that what patients need to remember, and this is probably going to be the most challenging part, is say that we have a patient that lives here in Honolulu and they fly over to Maui. Remember, Honolulu is going to be included in the DMEPOS round 2 program with the 90 others, right? But if a patient goes to Maui and they get a supply, Maui's supplier has to use the patient's bidding amount from their home region. So if a patient's residing in Honolulu, Maui cannot charge Maui prices for that one patient. They have to use the competitive bidding area prices in order to get reimbursed. They can't overbill the patient for it. And this gets very complicated because you can imagine we have a patient that lives, say, in Denver, because I came from Colorado. Denver is going to be one of the round 2. The patient is residing in Denver. They claim their taxes in Denver, and so they come to Maui on vacation, and they need some durable medical equipment. The supplier has to comply with Denver's competitive bidding prices. Okay, so this is kind of going to be a confusing point. I'm sure I'm going to get a lot of calls from different patients as this gets rolled out. Are there any questions in terms of DMEPOS?
So you talk to the suppliers and they know.
Uh-huh.
You do have some people that have gone through the process and wanted to become.
Yes. Yes.
Most of them?
I don't know how many, but I did make a presentation to the suppliers a couple months ago. The other thing I wanted to point out, because this has caused some concern, is the competitive bidding areas are specific to the area. So in terms of payments and the schedules that will be set, it's to the area. So they won't use like Washington, D.C. numbers or Chicago numbers or Denver numbers and amounts for Honolulu, Hawaii. They'll use this area and the bids from here to set their amounts. And that's caused some confusion as people are like, oh my gosh, they're going to only pay us what they pay Tennessee, you know. And that's not the case. It's the area itself. Another program that's been going on is the electronic health record incentive program. And in 2009, the American Recovery and Reinvestment Act authorized CMS to provide incentive payments to eligible professionals, hospitals, and critical access hospitals to adopt and use certified electronic health record technologies in ways that positively affect patient care. And so the program is not a reimbursement program for providers or offices to buy and install a EHR, although the incentives do provide money that can be used to help with some of that implementation of those EHRs. Because EHRs, as we know, can be very costly in terms of implementation as well as technical support. However, we do know that whenever you use an EHR, it does really help provide quality patient care. I can tell you from my experience as a Chief Information Officer, we did have a few EHRs that we were working with, and what we did notice was that the EHRs, the more integrated they become, the better care we were able to provide to our patients. And what I'm learning from the island, and again, I still consider myself somewhat of a visitor on the island, but there are a lot of mom and pop shops here on the island, and so a lot of these mom and pop shops don't have electronic health records, and many times they're working hard to, make a day-to-day living as well as see as many patients as possible. So I do know that there's a lot of challenges in terms of how we implement electronic health records and programs, and I do know and can understand some of their frustrations as well when it comes to electronic health records. But the EHR incentive program will pay up to $44,000 over 5 consecutive years to eligible participants. So it's money that providers can receive. There's a Medicare EHR incentive program, and there's also a Medicaid EHR incentive program. Now, Hawaii's working on their Medicaid EHR incentive program, and I do get some calls on what's the status of it, but it's the Medicaid office that's in control of rolling that program out. And so I've made a couple of calls, and I hope to go meet with them just to see what the status is, because I do know that you have to build certain components of that in order to start the program. The Medicare incentive program runs from 2011 through 2016, and the program is managed by CMS. CMS does manage it because it is the Medicare program. Payment adjustments begin in 2015 for providers who are eligible but elect not to participate. And providers or facilities must demonstrate meaningful use every year to receive the incentive payments. So the question is, what is meaningful use? And whenever you start demonstrating meaningful use, you have to attest that you're using it and it's effective. And so what you do is you fill out what we call an attestation statement, and you submit that as you're implementing the electronic health record. But meaningful use basically is effectively using your EHR by meeting specific objectives and clinical quality measures in ways that positively affect the care of patients. Again, remember, everything comes down to the patient level. So how are our patients benefiting? So an example, or a couple of examples, is like the objective would be generate and transmit permissible prescriptions electronically. So that would be physician order entry. When I started my career, basically what we had was a provider who would fill out a chart, enter the diagnosis, see the patient, enter the prescription, and then the patient would hand carry their chart in a sealed bag to the pharmacy, and then the pharmacy would get their chart, open it up, and give them their medication. Other systems have where they go see their doctor writes a prescription, right, paper. They take it to whatever pharmacy they want, and then they get it filled. Well, the EHR system allows our providers and kind of leads them towards using electronic systems to transmit prescriptions. That way patients get care faster. And in a health system or a hospital, if a patient's in a hospital and their prescription's electronically transferred, and we did this in our system, literally a patient could see the doctor, walk down the hall to the pharmacy, and their medication's already ready because that prescription was electronically transferred while they were walking down the hall. So part of my goal as the CEO was to minimize the amount of time a patient was waiting in a waiting room. So we implemented ERX very quickly so that our patients could get in and out very quickly after they saw their doctor. And the measure would be more than 40% of all permissible prescriptions written are transmitted via an ERX modality. So if a provider is transmitting 40%, then they're meeting the objective and the metric, and then they would qualify, potentially qualify for incentive payments. Who are our eligible professionals? Well, it's based on individual practitioners, and each may qualify for an incentive payment. So if you have a facility that has 10 providers, $44,000 over 5 consecutive years is a pretty significant amount of money for that facility to do, to build out its electronic health system or electronic health records. Each eligible professional is only eligible for one incentive payment per year, regardless of where they're working. But the Affordable Care Act did strengthen Medicare. It did build in a lot of free preventative service, so patients could get prevention, they could get different shots, vaccinations. They wouldn't be charged for some annual exams, which is important. And so we are seeing healthier patients and less admissions or less illness because of our prevention efforts. The law also helped cover the Medicare donut hole for Part D. The Affordable Care Act helped with that. It also built in strong anti-fraud measures. It provided incentives, like I went over a few already. And then it also is helping increase the number of providers out in the community. 2 years later, what are we seeing? So we've seen a lot in 2 years in terms of implementation of the Affordable Care Act. Again, those preventive services, we've seen numerous mammograms and colonoscopies in patients that typically wouldn't have gotten any, and so we're preventing illness, or we're catching it very early on and helping patients live longer. And we're paying for catching it early on through those prevention efforts. In 2011, an estimated 32 million people with Medicare received one or more preventive benefit, and in the first 10 months of 2012, about 23 million people with original Medicare received one or more preventive service at no cost to them. I already went over the making drugs more affordable, basically covering the donut hole that we saw with Part D when it was implemented, and this is a slide that kind of speaks to the savings that Medicare recognized. And then the exchanges, and we're going to see the exchanges really picking up speed here. We're going to hear a lot about it on the media. We're going to hear a lot of pros and cons. But again, remember, no matter what positive or negative we hear out there in terms of my role and my position and my professional background is, it's always about the patient. So is the patient getting the best care? Is the exchange going to help them get better care? Are they going to get timely and affordable care? And so I'm focused more on what benefits will the exchanges have than all the other things we are hearing right now in the media. But the Affordable Care Act, CMS, Hawaii has received $77 million in grants for research, planning, IT development, and exchange implementation. $1 million of that was in planning grants, and then the remainder was in the establishment of the exchange, and they are making significant progress in establishing this exchange here in Hawaii. PQRS, that's just the physician quality reporting system. There is an incentive there. It ends in 2014. It just has a lot of metrics, and providers have been using it for a while to show that they're providing quality service to our patients. The PQR's payment adjustment, it starts in 2013, and then it overlaps with the incentive for 2 years. The value modifier, which I talked about earlier, first reporting year is this year, and it affects payments in 2015. and it must include all providers by payment year 2017. So that value modifier, what is it? Well, basically it's just an incentive-based program based on how well hospitals perform on specific quality measures. This slide speaks a little bit more about kind of the program itself, but it is another incentive program. Again, as CMS is looking more towards what is the quality of care versus the quantity of care. Are patients really getting quality care? And if they are, then we want to give incentive payments for that quality to continue to move the system forward in terms of providing quality care. Accountable care organizations, you've probably heard about, that's another effort by CMS. The accountable care organizations, about 4 million beneficiaries are receiving care from an ACO right now, and those ACOs are growing in terms of what they're doing. You can get additional information on all of that stuff through these links. And that's my contact information. I do have a business card, and I'll pass it out to all of you if you're interested, if you would like one. And then I'll take any questions.
Do you know, over the past several years, you see more individuals who have health plans that are quote unquote called senior advantage plans? Do you think that will become more of the future?
I think yes and no. I think the big push really is, again, the patient-centric model, patient-centered model, and the affordable care model, and how to integrate, the accountable care organizations, but how to integrate patient focus into those systems, not only from the facility provider perspective, but across the whole system. So how do insurance companies and all of those incorporate that aspect into their system? So I do think it'll play an important role, but as far as how much or will it grow, it's hard to say, but I think the push again is really to incorporate patients into becoming a much more active player.
I have a question.
Please.
Yeah, I myself having to research some of the acts that you've identified.
Sure.
And I find it really difficult to get information, and it surprises me. So for example, I'm just curious, like Affordable Care Act, huge statute, got all kinds of rules, guidelines. I mean, you have to like do targeted searches, at least that's my experience, to find whatever's applicable currently. Okay. Is that your experience too? Is there some magic way that if you work for the government you can find out what's currently effective?
You know, I joined CMS in October, so I've had a pretty steep learning curve in terms of the programs and the laws that are impacting CMS, because 20 years of my experience was in Indian health. So I was very knowledgeable of their laws and what impacted them. And so, yeah, the Affordable Care Act is over 900 pages in length, right? It's about 940. And so reading through it and trying to find what's applicable to the area or the time can be challenging. What I do or try to do whenever I can't find something through the act or through a law is I do email the regional office or central office and communicate with someone internally to see what knowledge they have, or with one of our contractors that's out there. So if you have specific questions, I'm happy to channel those through and get answers for you, so you don't have to go through so much volume of pages trying to see. So that's why whenever someone or a group asks me to present, if it's one person or 100 people, I'm happy to present to try to get as much information out there, hear their questions. And part of my role as the Pacific Area Representative is to be an advocate for Hawaii and the territories, you know, because we're so far away from San Francisco and the regional office, and then so far away from Baltimore, that really there are issues here, you know, that need to be addressed, and someone needs to get that information to the hires up in CMS so those issues can be considered and addressed to the best of our ability. So yeah, I do know that I am building out my office to somewhat be an advocate for Hawaii and the territories in terms of CMS.
Do you think we have a lot of mom and pop shops here regarding the EHRs?
Yeah.
Do you think it's going to push out a lot of our older independent physicians?
You know, I hope not. I believe it or not, I've been making rounds, and I've been to different facilities, and I've been to this facility and, you know, others. But I really want to get into the mom and pop shops. I really want to go there in my role and really see how they're doing, what issues they have, if they're going to adopt an EHR or not, and if they're not, you know, how can CMS help them, you know, consider it, or, you know, what can we do to help? Because we don't want to push providers out knowing and recognizing the value they bring to the patients, because some patients have been with their providers since they were little, you know, and you don't want to change providers midstream because they really know your health care.
Along those lines, the criteria for the physician quality reporting system quality measures, can we find out more about what are those quality measures?
Okay, there's a lot of those, and so the best is to go online and type in PQRI. And there's a lot, you know, it'll say like blood pressure control and what percentage was their blood pressure controlled by, or how many patients have their blood pressure controlled, how many are on cholesterol medication, and their specific measurements and metrics.